general. So in dermatology, we use narrowband UVB specifically. So the sunlight emits UVA, UVB, UVC, and we have the ozone layer protects us from UVC, except for those whole areas apparently that's happening. But then the UVA, we don't like that. So over 250 sessions with UVA bulbs oftentimes increases the risk for skin cancer. So in certain conditions, we sometimes still use it in the world of dermatology, especially if deeper penetration is needed of UV light. So UVA1 in particular is useful still in dermatology, but most of the time we rely on the UVB spectrum, and specifically in that 308 to 312 nanometers, a narrow band UVB spectrum that can make our inflammatory cells shy away, T cells go away, lymphocytes go away. And these are the cells that when overly active in autoimmune skin diseases can result in overly active psoriasis, overly active autoimmune alopecia, overly active vitiligo. These inflammatory cells are targeting the melanocytes. They are targeting the epidermis and cause all kinds of dermatitis happening. And so oftentimes we find it useful, even in T-cell lymphomas, actually. We use phototherapy to suppress these abnormal inflammation that's happening in the skin. So across psoriasis, vitiligo, atopic dermatitis, it's commonly used. Psoriasis definitely most likely to hit home with insurance plans. Vitiligo a little bit tougher, and atopic dermatitis is a bit tougher too, but we can make a case for it. And it is in the guidelines as well that we can argue and appeal if needed to insurance plans. Now, depending on the device that you use, you can bill anywhere from a 9.6. Should I go into that now, Dylan, or should I wait?
Well, I mean, actually, that's a perfect transition into the next slide where we kind of take a look at existing phototherapy excimer lasers versus Exci308.
Yeah, so the billing codes across these, like, again, I started my own solo private practice, so I think I do my own billing. And so I think all of these became more granular to me as I went a little bit in depth with patient care on my own. And so across the different devices, you can have a lamp-based technology versus a laser-based technology. The billing codes range from 96900 to 96910 and upwards to 96922. And so it starts off with phototherapy booth codes all the way to laser codes. We even do photodynamic treatments as a separate different code. But the laser codes oftentimes have a hard time to be approved. They pay slightly more because of the slightly more complex device. And just for that reason alone, insurance plans tend to put the kibosh on reimbursing patients to get access to these treatments. And so oftentimes I've seen the vitiligo and eczema codes being approved with laser with the stipulation, you can only do 12 sessions and you got to bill a specific code for special therapy. And it's like a 96999, which is a special codes. And not all insurances reimburse for special codes. And so then, and my biller and a lot of electronic softwares don't even have special codes defined specifically for these vitiligo, eczema, or psoriasis codes, because they're special codes. They're versatile codes, but also they have to be manually entered, manually put a dollar sign to it. So it's just basically complicated and impractical. It slows everything down. And when you get a denial, you don't get paid. Sometimes you don't realize that right away. It's not like checking out at the grocery store. In medicine, you bill it out and you get your payment later. So if you forget to check later on what you received or what was denied, your business is going to take a hit. And so the laser codes are useful, but they're not practical or efficient to run a business with. The Exci308 runs on a traditional phototherapy booth billing code. And so oftentimes those are the 96910 code series. And those tend to be approved across more indications. And so oftentimes I don't have a cap. I don't have a limit on how many sessions is allowed. And I don't need to do a special code like a 96999 for the eczema light oftentimes. So it just provides a good answer. So there's a couple of patients where I prior to the Exci, I used up their laser codes for the year, and then they don't get paid for it anymore by their insurance, but they're not clear 100%. These are ongoing chronic skin diseases. And so I would switch them out to the Exci and so on, because I actually have I do have the laser, I do have the Exci, I have the photo booth. But we might use this from across different patient needs.